Here, we demonstrate the placement of a right axillary Impella 5.5 temporary ventricular support device. The patient is positioned supine with the right arm tucked. The infraclavicular region is prepped and draped in standard sterile fashion. The inferior border of the middle third of the clavicle is marked. An incision is made approximately 1 finger breadth below the clavicle. Dissection is carried down through the subcutaneous tissue using electrocautery. The pectoralis major is split in line with its fibers. The pectoralis minor is identified and retracted as needed, exposing the clavipectoral fascia. If division of the pectoralis minor is required, care is taken to avoid injury to the lateral pectoral nerve. The fascia is then sharply opened to expose the axillary sheath. The axillary vein is encountered first and gently retracted inferiorly, exposing the deeper axillary artery. The artery is then circumferentially dissected and controlled with vessel loops. Gently elevating the artery using vessel loops facilitates anastomosis and helps prevent inadvertent clamp injury to the brachial plexus, which lies just posterior to the artery. Systemic heparin is then administered, and the axillary artery is clamped using a side-biting clamp, such as a Satinsky clamp. An end-to-side anastomosis is then performed to a beveled 10 mm by 20 cm vascular graft using running proline. Routine tunneling is not recommended. After completing the anastomosis, the graft is de-aired and clamped. The 23 French Impella peel-away introducer sheath is then inserted into the graft and secured with graft locks. 1 or 2 graft locks may be placed, with care taken to place the locks between the retainers and the hub of the introducer to prevent inadvertent dislodgement. Prior to continuing, the ACT is confirmed to be above 250. The hemostatic valve is then lubricated using the provided silicone-coated dilator. An 0.35 wire is introduced through the center of the hemostatic valve, and with the aid of a 4 to 6 French catheter, such as a burn catheter, the wire and catheter are advanced across the aortic valve and into the left ventricle under fluoroscopic guidance. The wire is then exchanged for an 0.18 180 cm platinum plus wire. The Impella device is advanced over the wire into the introducer sheath. Care is taken to ensure that the entire pump cannula and motor housing are first seated within the graft before advancing the device centrally. The device is then advanced through the aortic valve and into the left ventricle under fluoroscopic guidance. Proper positioning is confirmed using TEE in the long axis view with the bend of the catheter aligned at the level of the aortic valve. The inlet is positioned approximately 5 cm below the annulus and directed toward the left ventricular apex, away from the posterior wall and mitral subannular apparatus. The placement wire is then removed. Only after wire removal is Impella support initiated. After this, the graft is reclamped at its base, with care taken not to clamp the introducer sheath. The repositioning sheath is then slid back to the red Impella plug. The graft lock tabs are then removed, and the introducer is withdrawn out of the graft prior to removing it using the peel-away tabs. The graft is trimmed so that the Impella suture hub sits at skin level, with the remaining graft buried beneath the skin. And the suture hub is secured within the graft using 2 heavy silk ties. Prior to removing the Fogarty clamp and the yellow pin, we reconfirm appropriate positioning with echocardiogram. Removal of the yellow pin allows the locking mechanism to engage, preventing inadvertent movement of the Impella after final positioning. The incision is then closed in layers, and the Impella suture hub is secured to the skin, followed by application of an antimicrobial dressing. Prior to leaving the OR, the Impella catheter position is documented at the sleeve lock along with the measured distance between the inlet and the aortic valve annulus as noted on TEE. Thank you for watching.